Welcome, everyone. Before we get started, I want to let you know that we have Spanish interpretation available during this webinar. If you would like to hear the webinar in Spanish and you're using a Windows or Mac, please follow the instructions on the slide. Also, if you're using an Android, we have instructions for you as well. I'm Dr. Sharon Smith. I'm a board member of the San Diego American Heart Association, and we're excited to have you all join us here today for this engaging panel discussion on something we believe deeply at the American Heart Association, and I know Sharp Healthcare cares as much as well. Women's heart health before, during, and after pregnancy. It is my pleasure to introduce to you our panelists for this evening's discussion, our webinar. We have Dr. Maren Nishimura. She's a board-certified physician in cardiovascular disease and internal medicine. She practices with Savaro Cardiovascular Institute in El Cajon at Sharp Grossmont Hospital. Dr. Nishimura completed medical school at the University of California, Davis, and did her internship, residency, and fellowship at the University of California, San Diego. We also have Dr. Joanna Adamczak. She's a board-certified physician in maternal fetal medicine and serves as the co-chief medical officer at Sharp Mary Birch Hospital and Sharp Mary Birch Hospital for Women and Newborns. Sharp Memorial Hospital and Sharp Mary Birch Hospital for Women and Newborns. Dr. Adamczak completed medical school at St. George University, and she focuses in the area of high-risk pregnancy. So just to share with you the mission of the American Heart Association, the American Heart Association, lovingly called the AHA, has a mission to be a relentless force for a world of longer, healthier lives. We are working with experts and volunteers across the globe to achieve this through a focus on the areas seen here on the slide. And it's always based in science and with equity at the center, guiding all the work that we do. More than 18 years ago, the AHA launched Go Red for Women to bring awareness that heart disease is the #1 killer of women, and that women are often misdiagnosed and unaware of the disease and the lifestyle changes that they can make to help prevent heart disease. We have made great strides, but there's still a lot more work that needs to be done. We've done great in bringing awareness to heart disease, educating women, and providing programs and resources for those that are in need most. That's why we are so grateful for those who have come alongside us, like Sharp Healthcare, in supporting the conversation as we work to break down barriers to health equity right here in San Diego. So for tonight's discussion, we will be discussing women's heart health, pregnancy-related cardiovascular conditions, and addressing cardiovascular conditions after giving birth. Cardiovascular disease, or CVD, continues to be the #1 killer of women, claiming more lives than all forms of cancer. And that's astounding for 2024. The reality is nearly 45% of women over the age of 20 are living with some form of CVD. And women also experience unique life stages that put them at increased risk of developing cardiovascular disease over the course of their lifetimes. Pregnancy-related deaths in the US has risen 140% over the last 3 decades. Cardiovascular disease continues to be the leading cause. Major racial disparities exist in maternal health outcomes. Women of color have a much higher likelihood to die from cardiovascular-related pregnancy complications. So we will touch on those topics further this evening. Cardiovascular disease during pregnancies leave women with higher lifetime risk of cardiovascular disease after delivery and increased risk for their children. Almost 2/3 of cardiovascular conditions can be prevented. Preventive care and early intervention are critical during pregnancy and postpartum. From adolescence to adulthood, life is measured by ages, stages, and seasons. The transition into early adulthood, motherhood for many, to the struggle to keep up while nature slowly decreases our physical ability to do so. As the milestones of a woman's life change, so do her unique risks for developing cardiovascular disease. There are four major risk factors for women. Women 35 and older are at higher risk of pregnancy complications and pregnancy-related death. Risk of pregnancy-related death in women 40 plus is nearly 8 times higher, so approximately 81.9%, than as a woman at the age of 25 and younger. Race and ethnic disparities in pregnancies-related mortality are significant. Peaking among Black women, mortality rate differences are significant. Black women are over 3 times more likely than white women to die of cardiovascular-related pregnancy complications. Black and American Indian / Alaska Native women are 2 to 3 times as likely as white women to die from any pregnancy-related cause. Hispanic and Black women are more likely than white women to have dangerous complications during delivery. Differences in the quality of pregnancy care and in outcomes have been linked to factors such as race, ethnicity, geography, income, insurance coverage, and access to care. Systems in place that promote racial inequalities can limit access to care and amplify pregnancy risk. Hypertension is on the rise. The rates of chronic hypertension, having high blood pressure even before pregnancy, have also increased. The dangerous hypertensive disorders in pregnancies include preeclampsia and eclampsia, and can make it harder for a fetus to get enough oxygen and nutrients to grow, increasing the risk of an early delivery. It is important to maintain a healthy weight as well throughout life, but especially before, during, and after pregnancy. Obesity is a major risk factor that could account for nearly 1/3 of a steep increase in U.S. pregnancy-related death. Obesity from pregnancy. So from 2011 to 2015, pre-pregnancy obesity increased by 8%, with the most severe obesity increasing by 14%. Maternal mortality increases with BMI. Pregnant women with a BMI at or above 30 face 3.7 times the risk of pregnancy-related death than other women. Pregnancy and childbirth can put women's health at risk, but many pregnancy-associated deaths can be avoided. Women should be aware of their risk factors, manage their medical conditions before pregnancy, and always communicate their concerns with their healthcare provider or healthcare team. Let's look at some stats. Again, women 35 and older are at higher risk of pregnancy complications and pregnancy-related deaths. The risk of pregnancy-related death in women 40 plus is nearly 8 times higher than women 25 and younger. Again, we said race and ethnic disparities in pregnancy-related mortalities are significant, peaking in Black women. Mortality rate differences are significant. As we could see, 42.8% in Black women, and we see 32.5% among American Indian, Native Alaskan Native women. We have 14.2% among Asian Pacific Island women, 13% among white women, and 11.4% among Hispanic women. Differences in the quality of pregnancy care and in outcomes have been linked to factors such as race, ethnicity, geography, and income. Systems in place that promote racial inequalities can limit access to care and amplify pregnancy risk. Hypertension, as we said, is on the rise. The rates of chronic hypertension, so having high blood pressure even before pregnancy, has also increased. The dangers associated with hypertension in pregnancy again includes preeclampsia and eclampsia, and can make it harder again for the fetus to get enough oxygen and nutrients to grow, increasing the risk of an early delivery. It is important to maintain a healthy weight, as said, weight throughout life, but especially before pregnancy, before, during, and after pregnancy, it's important to maintain a healthy weight. Obesity is a major risk factor and could account for nearly 1/3 of a steep increase in U.S. pregnancy-related deaths. Again, we mentioned those women who have a BMI at or above 30 face 3.7 times the risk of pregnancy-related death than other women. Pregnancy and childbirth can put a woman's health at risk, but many pregnancies associated deaths can be avoided again. So women should be aware of their risk factors, manage these conditions, and try as best possible to communicate these concerns with their healthcare providers and their healthcare team. At this time, we will have Dr. Nishimura join us, and she will give an overview of cardiovascular disease in women.
Sorry. Hi, good evening. Sorry, I had to unmute myself. I'm Dr. Randy Shimura. I'm one of the cardiologists at Sharp Grossmont. So at Sharp Healthcare, our mission is to improve the health of those we serve with commitment to excellence in all that we do. And our goal is to offer quality care and services that set community standards and exceed patients' expectations and are provided in a caring, convenient, cost-effective, and accessible manner. So Sharp makes it easy for you to get the care you need by the following examples. So we have 4 acute care hospitals. You're probably familiar with many of those. So Sharp Grossmont Hospital, Sharp Memorial Hospital. We also have Sharp Chula Vista and Sharp Coronado hospitals. We also have specialty hospitals such as Mary Birch Hospital for Women and Newborns. We also have the Grossmont Hospital for Women and Newborns as well. We have, from affiliated medical groups like SCMG or Sharp Community Medical Group, Sharp Reed Steely. And then there are also other special facility services that we offer. And the picture is an example of one of those. So it is the picture when we started a clinic in 2022 called Postpartum Heart Health Clinic. It is one of a kind in San Diego. It is a multidisciplinary clinic at Grossmont, consisting of both the colleagues from OB-GYNs as well as cardiologists in taking care of identifying patients that have, heart disease, hypertension during pregnancy, and also to facilitate care and transition into after delivery. Because a lot of times women, young women that are getting pregnant, they're not seeing doctors on a regular basis, and pregnancy is a perfect time to, identify at-risk population and intervene, and it can really make a big difference in their future heart health. And so we identify those patients, and then also after delivery, obviously they get very, very busy with the brand new baby. And so this period is called 4th trimester as well. It's a very important time period where both the OB-GYN doctors and the cardiologist see the patient, so that after the 4th trimester ends, the patient will continue to be followed to make sure that we're addressing all the risk factors, making sure that they don't go on to develop heart disease in the future. So we're really excited about that clinic. Next slide, please. Nope, where do I? Okay. So moving on to the poll question. All right, so which of the following is not a cardiovascular risk factor? Is it high blood pressure, obesity, low cholesterol, or age? Go ahead and try to submit the answer. Oh, great. Everybody got it right. So the answer is yes, the low cholesterol. So as opposed to low cholesterol, high cholesterol is a risk for cardiovascular disease. Next slide, please. All right, so why is heart disease so important? So heart disease, cardiovascular disease is the leading cause of death worldwide. And even though, when we think about heart disease and heart attack, we think about a middle-aged man clutching at the chest and falling to the ground, right? Having a heart attack. But in fact, the burden of cardiovascular disease for women and men are the same in the United States. And cardiovascular disease is the leading cause of death among women in the United States. It is the #1 cause of death. Yes, next slide. Okay, and overall, 1 in 3 women will die from cardiovascular disease, and it kills approximately the same number of women as all forms of cancer, as well as chronic lung disease and diabetes combined. And in 2014, 1 out of 32 female deaths was from breast cancer, whereas 1 in 3 was from cardiovascular disease. Next slide. But even though it is very common, it is the #1 killer of women, fortunately, cardiovascular disease is a largely preventable disease process, and nearly 80% can be prevented with better lifestyle choices, such as not smoking. And this is not just limited to cigarette smoking, but also vaping as well. A lot of people consider vaping as a healthier alternative than smoking, but definitely it was added to the most recent, American Heart Association guidelines that it is increasing your risk of heart disease, and we do recommend stopping it, similar to cigarette smoking. And also regular exercise, that's 30 minutes a day, 5 days a week of moderate intensity exercise. And you don't necessarily have to run a marathon for this to count. You can do walking, and that counts as well. And of course, eating a healthy diet. So diet that's rich in fruits and vegetables, high fiber, try to incorporate fish several times a week, and lean meats like chicken and turkey is helpful. Okay, what are the cardiovascular risk factors? So if you have a personal history of coronary disease or strokes, if you had a heart attack, stent, you have a stroke, definitely you're at increased risk of having another event again. So you definitely have to be aggressive about, controlling risk factors. If you have a family history of early coronary disease, so if you have a dad or male relatives under the age of 55 or female relatives under the age of 65, especially, first degree relatives, so mom, dad, or brother or sister, you definitely should be watching out for any signs or controlling the risk factors. High blood pressure, so we're going less than 130/80, and make sure that you're checking that regularly with your primary care doctor. Cholesterol, so cholesterol panels, we do it every couple of years or so. There's a lot of numbers, but the main thing that we're concerned about is the bad cholesterol, which is LDL. We want that low. HDL, which is the good cholesterol, and we want that high. And that could be, increased with good diet and also exercise as well. Diabetes, especially if you have family history, there's a blood work called hemoglobin A1C, which tells you the average blood sugar over the course of 3 months. So that's going to tell you whether or not you're pre-diabetic or have diabetes and how well it's controlled. So you want to monitor your A1C to make sure your diabetes is well controlled. And obesity, making sure that your BMI is within healthy target limits. That's definitely going to be important to prevent development heart disease. And chronic kidney disease, we routinely test kidney function in blood tests. If you go to primary care doctor and they order something for a blood test, they're going to be checking for kidney function, and making sure your kidney function is good is also important. And smoking, I think that's the best thing. If you're a smoker now, that is the best thing you can do to improve your heart health, is to stop smoking. And it's never too late. As within like a year of stop smoking, there's a beneficial effect in your heart health. So you definitely want to do that sooner rather than later. Next slide, please. And what are the risk factors that are specific to women? So timing of menarche, whether it's early, less than 10, or late, later than 15, that tends to increase your risk of cardiovascular disease as well. Early menopause, whether it was spontaneously like that or was it done by surgical, anything less than 40, that tends to increase your risk as well. Polycystic ovarian syndrome associated with development hypertension, heart disease, and stroke. Autoimmune diseases are also more common in women, and inflammation tends to increase your risk of developing cardiovascular disease as well. Breast cancer, so there are chemotherapy agents that are associated with being cardiotoxic to the heart, and radiation also, because it's targeting the chest area right next to the heart, that could increase your risk of coronary artery disease or valve disorders as well. And then hormone therapy, and whether you're doing it for birth control or also mainly for postmenopausal menopausal symptom management, that could alter your risk of heart disease as well, and stroke. So you want to watch out for that and make sure you discuss about your risk factors, whether or not you already have a diagnosis of that with your doctor before you start hormone therapy. And what we will focus on today for the remainder of the talk is the pregnancy-associated risk factors that can lead to complications during and after pregnancy.
Thank you for that talk. I'm Joanna Adamczak. I am a maternal fetal medicine doctor over at Sharp Mary Birch. I practice caring for high-risk moms and their infants. Next slide. Poll question. Next slide. Nope. No poll question. That's okay. We'll skip on. Oh, here we go. All right. True or false? Nearly 75% of cardiovascular disease can be prevented through better lifestyle choices. Good. I hope we all answered true. We definitely learned that in the two previous presentations. So, pregnancy in your heart. This is a really important topic because, as previously mentioned, women don't often seek primary care and don't seek care through a physician, and usually only seek that care when they're pregnant. And pregnancy results, as you all know, in multiple changes to a woman's body. And really, it can be likened to what's called a cardiac stress test for the mom. We know that there are several complications of pregnancy, such as preeclampsia and gestational diabetes, that are independent risk factors for future heart disease. These complications can occur in roughly 20% of all pregnancies, and they're associated with a 2 to 4-fold risk of future cardiovascular disease, which is quite significant. Next slide. So complications during pregnancy that we mentioned are independently associated with heart disease. These are hypertensive disorders, and there are 3 hypertensive disorders. Preeclampsia, which we'll talk about a little bit later on, is only specific to pregnancy, which is a disorder of high blood pressure plus microvessels that can affect different organ systems such as your liver and kidney. Then there's gestational hypertension, which is elevated blood pressure that only develops during a pregnancy, and chronic hypertension, which is hypertension that exists before a woman gets pregnant, and gestational diabetes that can all increase your lifetime risk of cardiovascular disease. Next slide. So as I mentioned, pregnancy is nature's stress test. And what that means is that because of all the hormone changes of pregnancy, there's increased blood volume in a woman's body during her pregnancy. This can be up to 50% higher than in the non-pregnant state. This then leads to extra work for your heart. And there can be elevations in blood pressures and blood glucose throughout the pregnancy. And as the name labor implies, labor is very difficult, and that can also increase the stress and the workload that your heart experiences. And so how a woman handles the complications or kind of the increased workload of a pregnancy really tells a lot about her future heart health. Next slide. So we mentioned preeclampsia. What is preeclampsia? The preeclampsia is a disorder that only develops during pregnancy, and its hallmark is high blood pressure. Preeclampsia can double a woman's risk for heart disease and stroke over the next 15 years. We know that there are many risk factors for preeclampsia. Having it previously in your pregnancy, if you're pregnant with multiples, so twins or triplets or even higher, can increase your chances of preeclampsia. Having elevated blood pressure before pregnancy increases preeclampsia. Having pre-existing diabetes, so type 2 or type 1 diabetes are risk factors. Autoimmune disorders such as lupus, kidney disease, and unfortunately, obesity is a known risk factor for preeclampsia, which is certainly concerning given the rates of obesity. Next slide. So the complications of pregnancy are not just to mom. They are both to mom and to baby. We know that preeclampsia causes disorders in the blood vessels, which can lead to growth restrictions, so a small baby. It can lead to preterm birth, which means delivery before 37 weeks of pregnancy. It could lead to something called placental abruption, which is when the placenta separates from the uterus, and this is usually caused by elevated blood pressures, which kind of have a shearing effect on the placenta and separate the placenta from the uterus. Then there's eclampsia, which is a extremely significant complication of preeclampsia, which means a seizure during the pregnancy, which can have a dramatic impact on both mom and baby. And preeclampsia also leads to organ damage, such as the liver and kidney. And then, as mentioned, it leads to future risk factors for cardiovascular disease. Next slide. So treatment for preeclampsia. Unfortunately, even in this day and age, there is no treatment for preeclampsia other than delivery. That doesn't mean that once preeclampsia is diagnosed that you will be delivered. It may mean that you are admitted to the hospital for further monitoring, further blood pressure monitoring, monitoring of your lab work, monitoring of baby, and you may be administered medications to help lower the blood pressure and stabilize the blood pressure. You may be given medications to prevent seizures, so eclampsia, and you may be given medications called corticosteroids, which is a type of steroid to help promote the baby's lung development in anticipation of a premature delivery, since again, the only treatment for preeclampsia is delivery. Next slide. So now on to gestational diabetes. So as the name implies, it's a type of diabetes that develops during pregnancy. It usually develops between 24 and 26 weeks of pregnancy, which is when it's tested. And it can have an impact on later cardiovascular health, increasing cardiovascular disease later on in life. It also, similarly to preeclampsia, can have an effect on baby. It can make the baby extremely large, which can increase delivery complications. It can also increase the rates of cesarean sections because the baby is too large to fit in the birth canal. It can cause premature delivery and respiratory problems for the kiddo. And it may actually cause low blood sugars in baby, necessitating baby to go down into the neonatal intensive care unit. And then it can also increase the rates of development of type 2 diabetes later in life in that child. Next slide. So in terms of diabetes, reaching a healthy body weight after pregnancy is extremely important. You should visit your primary care physician to have your blood sugar tested regularly. As mentioned before, eating a healthy diet, staying active, and really monitoring your baby and letting your pediatrician know that you did have gestational diabetes is important for the pediatric team to then monitor the kiddo. And typically after pregnancy, your blood sugars do return to normal, but there is a certain subset of patients who have gestational diabetes that will then immediately turn into type 2 diabetes. So what we do recommend is that you have a repeat test after pregnancy. So usually 4 to 6 weeks after delivery to test to see if there is evidence of pre-existing type 2 diabetes. Next slide. So what can you do to help your heart? As I said, you should really, after pregnancy, let your primary care team know about these complications in pregnancy because they do increase chances of cardiovascular disease later on in life. Practicing healthy habits is extremely important. And of course, we all know that it is hard, but this is all intertwined. So being physically active, having a good diet, avoiding smoking and secondhand smoke, getting sleep, monitoring your weight gain is extremely important. And we really do recommend that women go down to a healthy weight after pregnancy, and breastfeeding is a wonderful way to help decrease that pregnancy weight gain. And that is something that we encourage all moms to do. Next slide. So heart health after pregnancy, things to look out for and things to let your primary care team know, especially if you are at risk. So headaches and vision changes can be a sign of elevated blood pressure, chest pain, heart palpitations, which is a feeling of your heart kind of racing as if you've had 5 cups of caffeine. That could be a sign of heart disease to let your physicians know about. High blood pressure is certainly something that needs to be monitored. So 140/90 is kind of our pregnancy hallmark, but after pregnancy, really that is considered hypertension. So that is something you should certainly let your team know about. Shortness of breath or difficulty when lying flat can be a sign that your heart is working a little bit too hard and you may have cardiovascular disease. And leg swelling can also be a sign of cardiovascular disease. Next slide. As we mentioned, mental health is extremely important, and this is part of that 4th trimester. Typically in pregnancy, we've always talked about a 3-trimester, 1st, 2nd, and 3rd. But what we fail to recognize is that the postpartum period, kind of the 4th trimester, is extremely important in terms of overall well-being, mental health, postpartum depression, and it's extremely important to know about those signs and symptoms, talk to your partner, talk to your family, friends, colleagues. You'd be surprised how many women have postpartum depression and don't really talk about it. And there are many social support groups that are out there, including at Sharp Mary Birch on our website. Next slide. And then some references there for you. Next slide. I think that's it. And we'll open up to questions.
Okay, we do have a couple questions that were submitted. The first question is, and I'm not sure which of my panelists will be able to answer this. Maybe both of you can chime in. But what are your recommendations for pregnant women with beta thalassemia minor?
I guess I'll take it from a pregnancy standpoint. So beta thalassemia minor is something you should let your OBGYN know, because that is something that can be passed on to the baby, especially if dad is also a carrier of beta thalassemia. But beta thalassemia is largely associated with anemia, and beta thalassemia minor usually does not have many symptoms associated with it, especially during pregnancy. But again, if dad is a carrier of one of the genes, then that can increase the chances that baby is affected by actual beta thalassemia. Okay,
thank you for that. Our next question, and this one is for you, I'm sure, Dr. Adamczak. Can you share some information on perinatal cardiovascular disease or cardiovascular concerns?
Let's see. Can you ask the question again? So cardiovascular concerns. I'm like, I think that's kind of what we
perinatal cardiovascular issues. Maybe
issues. So, I mean, like we said, heart health is extremely important. So women that have high blood pressure before pregnancy certainly are considered high risk, and that can increase their pregnancy complications. So cardiovascular risks can also be associated with pre-existing heart disease. For example, if you were born with a cardiac defect, that can increase your chances of complications during pregnancy. And other issues such as autoimmune disorders, like we said, lupus, all of those increased chances of cardiovascular complications, which then can really lead to preterm delivery because of either preeclampsia or because a woman experiences heart failure during the pregnancy, where the heart just does not work hard enough. Again, that stress factor of pregnancy is there, and some hearts, unfortunately, are too compromised to allow the workload to be safe, and they start developing symptoms of heart failure. And so that certainly is something that needs to be cared for immediately. I hope that answered the question.
Okay. Next question. Can you talk about PPCM? What are some signs?
Yes, I can kind of add to that too. And also kind of the last question, the perinatal, was it asking about the baby or was it for the mom? It was for the mom, right? I think. Or sorry, oops. Oh yeah, no, I'm not. I mean, but anyway, so yeah, for the mom issues, yeah, we talked about the peripartum cardiomyopathy, which is a specific cardiomyopathy that occurs in pregnant women and also within the first 3 months of delivery. And yeah, cardiomyopathy, perfect. So it specifically, it's kind of like, as we said, the pregnancy is a stress test. And if you have, the exact mechanism is not known, but this stress of pregnancy and delivery and maybe some genetic hit or like familial disposition, it leads to severe heart failure in pregnant women. The heart becomes weak. So heart is a ball of muscle essentially. And when the heart is weak, it doesn't pump as well. And it also becomes dilated. It is, and some of the symptoms you could see are, obviously pregnant women, they have shortness of breath to begin with and edema, but it will be much severe than that. So, severe shortness of breath, severe edema, whether you're developing during a pregnancy or shortly after delivery, definitely concern for peripartum cardiomyopathy. Shortness of breath when you're laying down, palpitations or dizziness, those are all concerning signs. You definitely want to seek out, medical attention to make sure you get the echocardiogram done. Key thing about peripartum cardiomyopathy, though, is if the heart function doesn't recover after the episode, your risk of mortality or recurrence of heart failure during the subsequent pregnancy is quite high. So would definitely try your best to avoid pregnancy if you were diagnosed with this condition. Other conditions that could affect the mom, specifically during pregnancy, we talked about preeclampsia and eclampsia. Other thing is like SCAD, or spontaneous coronary artery dissection, which is a very specific type of heart attack, where normal heart attack is a blood clot that's forming in the blood vessel, but in SCAD or dissection, the layer of the heart vessel comes apart and that leads to blockage. And the classic scenario is a young woman who gave birth recently, present with chest pain, and it looks like heart attack in every way, but when they do the angiogram to diagnose, they see the torn blood vessel. So that's very classic finding, a classic condition that could affect pregnant or women that gave birth recently. Other thing is stroke is another thing. So women, when they're pregnant, the blood-brain barrier is more permeable and they're more prone to stroke, even at lower blood pressure at normal. So, in any other person, they might be walking around with blood pressure 160 over 100. It's not ideal, but it's not going to lead to immediate stroke. It's, we can take it more slowly, control it more slowly over the course of weeks to months. But if that's happening to a pregnant woman, that's an emergency. They got to go to the emergency room because they could have a stroke at much, much lower blood pressure, like 160, 170, stuff like that. So that's another peripartum cardiovascular thing to consider. One more, palpitation. I see that a lot. So when the woman's pregnant, the heart's stretched out and there's more cardiovascular or cardiac output. And when that's happening, you tend to get more palpitation, extra beats or skipped beats. And I see a lot of those women that have that. It tends to get better after pregnancy, but if you're having lots of symptoms, definitely, see your OB or maybe see a cardiologist, talk about it. Hopefully it answers some of the questions. Yeah.
Okay. Are there other questions? You both talked about, different disease processes and how they impact the heart, but just perhaps someone in the audience may need a refresher or a little bit more understanding on the impact of anemia on the heart and how it impacts the mother during pregnancy.
Do you want me to take that one? I'm happy to take that one. So anemia certainly is important during pregnancy because it causes you to have a low hemoglobin and hematocrit level. So your blood is pumping faster, per se, for your body, and your hemoglobin and hematocrit need to be at a certain level to maintain placental health and therefore maintain adequate blood supply to both the placenta and therefore to baby. There are certainly different thresholds for anemia and different types of anemia. So there's an iron deficiency anemia, which is very common in pregnancy and very common in women in general, and that's oftentimes due to diet. But then there's other types of anemia like sickle cell, which have a significant impact on a pregnancy and on the development of the fetus, again, placental health. So anemia is a very large and broad topic, but certainly can impact pregnancy when when the anemia is not treated in terms of replenishment of iron stores, or finding out the cause for the anemia.
Thank you. We have another question. Which chronic heart conditions requires a mother to have a C-section?
Well, the short answer is really none. There aren't any heart conditions per se that require you to have a C-section. I would argue that, in fact, a woman should always try to have a vaginal delivery because it is less stressful on her body than having a C-section. We oftentimes minimize C-section and the impact that a C-section has on our bodies, but it is a major surgery. It is an abdominal surgery where we are right next to different organs, bowel and bladder. So there are increased rates of inadvertent injury to different organs. There's risks of infection, bleeding, and all of that actually cause a larger stress on your heart. So in general, and again, broadly speaking, most chronic heart conditions do not require you to have a C-section as part of your birth plan.
Okay, and there's a question, aside from prenatal vitamins, what other supplements do I need to ensure are incorporated into my diet?
I'll let our cardiologist take that.
Well, from aside from prenatal vitamins, yeah, no, that's mainly what I recommend, is making sure that you're getting adequate amount of folate or folic acid. If you're anemic, definitely want to have enough iron, and a lot of the prenatal vitamins do cover different variety of vitamins and minerals in there. So I would think I don't necessarily recommend anything besides that, and having healthy diet on top of that.
I was actually going to say the exact same thing. Prenatal vitamins kind of incorporate everything. And short of prenatal vitamins, really, a good diet, you could get so much more nutrition that is absorbed through your gut through a healthy diet. So we really do stress that all the time.
Okay. Is there anything different to consider for a first pregnancy versus a second in regards to heart health?
Certainly. So, there's many differences to consider. Really, if it's the first pregnancy, we don't know what the outcome is going to be. And so that affects your second pregnancy, right? If you had preeclampsia, if you had gestational diabetes, what complications did you have in that first pregnancy that then can impact the well-being of the second pregnancy? First pregnancies really depend on the age of the mom, right? We know that your heart has different risk factors as you age. So the outcomes for a woman having a child at 20 years old versus the outcomes of a woman having her first child at 35 years old are significantly different in terms of pregnancy outcomes and heart health.
Okay. Are there any other questions before we wrap up our Q&A? Well, we certainly want to thank our panelists for today. But before we totally end this session, I would like to announce the winners of our opportunity drawing. We have Anita Lunas and Malia Morgan. So we will be emailing each of you regarding your prize. And again, I want to thank our panelists for joining us today and sharing your expertise and your knowledge. I worked at Sharp Memorial and often made visits to Sharp Mary Birch, so I do understand the gist of your work and just how important it is. I actually saw some mothers that had complications we had to bring from Mary Birch over to medical and medical and cardiac ICU, which is where I worked. So I appreciate the work you're doing at Sharp, and I'm sure many others do. To my guests, I want to say that you're all leaders and voices in our community. You're leading the way in patient and community wellness, and we appreciate that. And I know everyone who joined us today is leaving feeling a bit more inspired. You've gained a lot of knowledge, and we do hope that you will share this knowledge with your family and your community. And the main thing I think that we can take from this is creating a healthier lifestyle, making better choices, and just really paying attention to our heart health. For those of you that have joined us, you can expect to receive the recording of this, as well as take-home resources in your email. And on behalf of our panelists, again, thank you again for joining us today. And we would like to say a special thanks to Sharp Healthcare for being our community partners and allowing us to present this information to our guests today. Thank you.